Hello, everybody, wherever you are on the globe. So for some of you, it's a good morning. For some of you, it's noontime, like here in Tel Aviv. For some, it's nighttime. And again, I want to welcome all of you to this unique webinar, which will deal with something which is different than what you actually are familiar with. And I'm talking about a little bit outside the box stuff. As most of you know me, and I can guarantee that there are a lot of friends of mine in the audience, I will be presenting to you today a concept. I'm not going to talk about many cases or about a certain procedure, but I want to talk a little bit about a concept. And that is a concept that we have developed over the last 20 years or so. So I will be showing you only, I think, 4 cases, 2 of them which I treated about 10 years ago, and 2 that I treated quite recently. And the reason for that is that I want to show you how we evolved to some kind of a revolution in the way that we think and execute our treatment plan from start to finish. Now, those of you probably who would have questions, please bear till the end, and I will do my best to answer all questions in order. So, in those difficult times of Corona that most of us are in our homes, in a lockdown, maybe it was some kind of a scheme to get all the dentists with some additional education that you don't have the time to in your everyday office. But let's make the most out of it, and let's start with our presentation for today. Hello, I'm Ziv Mazor from Tel Aviv, Israel, and I would like to speak with you today regarding past, present, and future in ridge atrophy treatment concepts. Now, I would like to show you a few cases that will demonstrate the principles that we are following nowadays regarding the atrophy of the ridges, both mandibular and maxillary ridges. So we will start first with a case of a lady, 65 years old, that already had implants in the past. And all her implants, except for one, failed. So we see the panoramic view on the left that shows us that there is only one implant that was left over there. And on the right, we can see the ridge without the teeth, and the patient is walking with dentures for the last few years now. Now, when you look at the lower jaw, you can actually see that the ridge is flattened and there is almost no height of bone present. Now, also you can note that the mental foramen is coming out right on top of the ridge. So that's quite a complicated situation here. When we look at the Cbct of the upper jaw, we can note that the ridge is a little bit thin due to the fact that she had gone without teeth, and with a denture, we get resorption mainly from the buccal aspect. In the posterior areas, we still have some bone, but the bone is also deficient, both in height, which probably will require some type of sinus augmentation, and also the bone looks a little bit, I would say, soft and decreased density of the bone. Now, my plan was, and I always plan my cases in a 3D digital software, whether I'm going to use a prefabricated surgical guide or not, but that will guide me here where my implants should be. And as you can see, I'm not a big advocate of the all-on-4 concept. I'm a big advocate of the all-on-more concept. So the idea here was to place 5 implants on each side. And again, we would require to do some kind of bone GBR procedures like sinus augmentation in the back and a little bit of ridge expansion in the front. So in order to place our implants in the right position, we are planning a surgical guide. And what you see here is the prefabricated plan of the surgical guide. And by looking at the planning, you can also see the nature and density of the bone. If we look at the left slide, you can see the implant, you can see the buccal bone and the lingual portion, which are stained in green here, and in the middle, you can see the existing trabecular bone. And when you look at the density, you see that the color of the bone resembles also the color of the soft tissues. And that means that we have a very soft bone here. So here are the surgical guides that were fabricated. This is what we call a pilot guide because it will only give me the position and the angulation of where my future implants should be. So we expose the ridge, and you can see that we have in some positions a very narrow ridge, as we have seen on the CT scan. We see the guide, and you see how perfectly and accurately the guide fits the underlying bone, and we start to do the pilot drilling to mark where the implants should be. After that, I go to the back and I do my closed sinus augmentation procedure. Now, that is a case that was treated almost 10 years ago. At that time, osseodensification was not an option, but I still went to a minimal invasive sinus approach. And what I did here is a balloon sinus elevation in the posterior aspect. So you can actually see here the delivery device of the balloon. The balloon is inflated, the sinus membrane is pushed upward, and now I'm ready to utilize my graft material. And what I've been utilizing for quite some years now is the Novabone, which is a synthetic material, calcium phosphosilicate, and it comes in a cartridge. And the diameter of the cartridge here is a 3 millimeter metal tip, and that fits perfectly to our site. So we inject the material here in this side, and now we can insert the implant at the same time. We go to the front, and in the front we do a little bit of ridge expansion. Now at these times, almost 9-10 years ago, we used manual expanders. And actually you can see here a typical example of the expander, which looks like a screw. The problem with those manual expanders are that sometimes if you apply too much force, it creates cracks in the bone. In the other side, in the back, I use those ancient instruments, which are called osteotomes. Now, I've been using osteotomes for many years, but for the last 6 years, I haven't used it even in a single case. So 9 years ago or 10 years ago, I was using those osteotomes to infracture the sinus floor and then place the graft material. And I used here only PRF as my graft material. Now we can talk a lot about different graft materials to be used in the sinus, and that can be a really topic just of a single complete webinar. And I published in the literature in 2009 using PRF as a sole graft material for sinus augmentation procedures. That was for a lateral window approach, But later on, it was published by the French group of Alain Simon-Pierry and others that PRF can be utilized also for closed sinus augmentation, as shown here in this specific case. So there was no particulated graft that was used here, only PRF. Then I inserted the implants, and I used the PRF, the Lprf, to cover my augmentation and ridges. Now, what is the benefit of using Lprf for such indications? First, acceleration of healing, not just soft tissue, but also hard tissue. We know that it has a big effect on angiogenesis. Second, if you do have some places where the flap is not completely closed, there is no problem because PRF can be left exposed. It also has an antibacterial activity. And third, we will gain more keratinized tissue. So we close, and you can see the post-op panoramic X-ray showing you all the 10 implants that were placed. Now let's go to the mandibular part, which is much more complicated. What are we going to do here in this mandibular part? So the idea, or if we go back one slide, the problem here is, of course, the position of the mental foramen, which comes right outside the ridge, right in the middle. So we don't have any bone height in the posterior regions to place our implants. Now the patient, she insists of having a fixed restoration. So what are the options? Well, we can consider doing just like 4 implants in the front with a overdenture or an all-of-4 concept, but the cantilever would be too risky. So we go for a outside-the-box treatment plan. And the outside-the-box treatment plan means that I'm going to place implants not only in the front, but also in the back. And here you can see at the position on the posterior left, I'm going to place 2 implants which will be buccally to where the nerve is. And the same would be also on the other side. And in order to place the implants in the correct position without damaging the nerve, we have to construct a surgical guide. And that is the surgical guide that we designed. And you can see here very nicely that in the front, there is no problem with the nerve. And of course, we can place the implants right in the middle of the ridge. In the back, that's where the nerve is, and that's where our implant would be, just sideways, buccally to the nerve. So here is the surgical guide that we constructed, done with the 3D software. And of course, we have fixation screws here in order for the guide not to move and to be very accurate. And once we have a surgical guide, we really don't need a very good eyesight
that they can
like
never see
this
coming.
guy has. Because that eagle, he has perfect eyesight and he knows exactly what he's looking for. So here is the ridge, opening up a flap, seating the guide. Now the reason that you see here an opening in the guide is that the nerve is right there, so we don't want to compress the nerve. In the anterior segment, we can place the implants exactly as planned, right in the middle of the ridge. While in the posterior segments, and here you see beautifully where the nerve is, how it comes out from the ridge. So those are the anterior implants, and those are the 2 osteotomies which will be made laterally to the nerve. So again, that is on the other side. You can see nicely the mental foramen coming out. And that's how it looks on a CBCT post-operatively. You can actually see here, that's where the nerve is, right where my pointer is, and that's where the implant is, exactly as planned. On the other side, again, you can see where the nerve is, right there, and you can see that the implant sits sideways. Now we take our PRF again, and we will cover the entire ridge with PRF. Close it up, and here is the post-op radiographic appearance. So we see 2 narrow diameter implants in the back, 4 implants in the front, and 10 implants in the upper jaw. When we take a post-op CBCT, we see very nicely the trajectory of the nerve, which stained here in red, and the implants. And you can see that there is no contact between the implants and the nerve. Next stage is uncovering of the upper implants. And in this slide, you can very nicely see that we gained a lot of keratinized gingiva. Now, why did we gain the keratinized gingiva? Mostly because of the use of Lprf. So we can sit now abutments and construct a temporary restoration for the upper jaw. And I can tell you that once we gave the patient the upper temporary, she was so happy. Now we go to the lower jaw. We place transmucosal abutments on the implants, and we will construct a screw-retained restoration, as you can see here. That will be screwed into the implants, and of course the patient would have a fixed restoration with the ability to clean between the implants. Here is an 8-year post-op of that particular case. So actually you can see how the implants are functioning. Everything looks beautiful. No infections, no bone resorption. Patient is extremely happy. So this is a way how by an outside-the-box approach we can address that ridges, the atrophic ridges. Let's take another case. And we're talking here about a 55-year-old female patient which has a dental phobia. And she had never been to a dentist before except for once getting an upper denture. Now she comes to my office and she is seeking fixed restoration. So we send the patient first for CBCTs, and you can see that's how the lower jaw looks like. That's what's left of her lower dentition. And that is the upper denture that she's going with. Now, when you look at the panoramic X-ray right here, you can actually see that, well, we might have sufficient bone. And when you look at the ridge here, you would say, hey, that looks perfect. So probably we can place implants here. But my friends, never judge just by appearance. Because when we send a patient for a CBCT, you can actually see that we are talking about a very narrow ridge. You can see it here right in the bottom, but when we go forward, you will actually see that that is what we are left with in the anterior region. Now you scratch your heads. Well, what are we going to deliver the patient? Here is the lower jaw. In the lower jaw, we see a similar phenomena. Even though we have a little bit of width, still that's too risky. I mean, there is no way we can place an implant in a 2 millimeter ridge. And again, that was a case that was treated over 10 years ago. So what would be here the treatment options? That is the lower jaw in 3D reconstruction. And we need to give the patient a treatment plan. And again, we have to follow the patient desire, and the patient is seeking for fixed restorations. So we decided first to go and treat the lower jaw. Now, in the lower jaw, the ideal is to place, of course, as many implants as we can. Now, in order to place as many implants as we can, we need to do GBR procedures because the ridge is too narrow. Now, when we place the implants in the 3D software, we can immediately see that we are lacking some bone, especially here on the lower posterior side. So we know that we would need some kind of GBR, horizontal GBR over there. And also, in order to position the implants in the right place, we would need to cut a little bit of bone here. Otherwise, we will not be able to sit the implants. So sometimes we need to think a little bit outside the box and go against our first, I would say, reaction, because we always aim to preserve the bone and do GBR. But sometimes, for placing the implants in the right prosthetic area, we would need to cut a little bit bone off to level the ridge. So here you can see the amount of bone which we would need to cut. Now, that has to be very, very accurate, because if it's not accurate, we would not be able to sit our surgical guide. So that is the plan. We extract the teeth in the software, and we create what we call reduction guide. Now, we have done reduction guides for many years already. That's a 10-year case that I'm showing you right here. And this reduction guide would direct me exactly how much bone I would need to cut in order to place my surgical guide. And that has to be very accurate. Otherwise, I would not be able to sit my surgical guide and place the implants. So here is the case. That is the clinical situation. Extraction of the teeth, cleaning all the granulation tissues, and sitting the reduction guide. So you see how accurately the reduction guide sits. We clean all the granulation tissues. And now we take our piezo device and we cut the bone from buccal to lingual, all the way in. So you can actually see the tip of the piezo that goes directly from buccal to lingual. We would take this chunk of bone, and now we have a few possibilities. We can grind it up and use it as our graft material, autogenous bone. So here is the ridge after cutting it, and you can see that it has a resemblance perfectly to what we had to begin with when we planned the case. Now the surgical guide is seated, and we can now start drilling through the surgical guide. And of course, after taking off the guide, you can see how accurate those drillings are. And that tells us that the plan and the execution are accurate. So we see now the implants. Those are narrow diameter implants, 3 millimeter in diameter. You can actually see here that in the plan, there are 2 implants that needs horizontal GBR, exactly as seen here in reality. And those 2 screws here are tenting screws, which I'm placing here, that will now be support for my membrane and graft material. So actually you can see that I placed stock abutments on the front implants, and those 2 implants that needed horizontal GBR are not going to be immediately loaded. So we add some more bone, especially on the buccal aspect, to support the long-term stability, and I usually like to use non-resorbable material just on the superficial aspect of my GBR over there because I want long-term stability. But close to the teeth, I would rather use either autogenous or allogeneic. So here is a prefabricated temporary bridge which is reliant immediately on top of the implants, and you can see here the appearance of the lower jaw right after my first surgical treatment. When we look at the Cbct that is taken afterwards, you can actually see here that the difference between the befores and the afters. You can see here the horizontal GBR and also the tenting screws that were placed there. In the front, you see the narrow diameter implants, and again, you see the bone that was added here as well with the screw. And that is the other side with the implants in the right position, like here. Those are the reconstructions. Again, you can see the bone, which is the red, and the implants, which are the blue, in the right positions. That is a post-Cbct that was taken 4 months later. And we know from that Cbct and reconstruction that in order to expose those implants, I would probably need to get rid of some bone that was regenerated on top of those cover screws. Now let's get to the upper jaw, to the fun part, where it looks to you as if you have sufficient bone, but again, we said we should never judge by appearance. So when you look at the existing ridge, you can understand that there is not enough bone to secure implants. And this is a 3D reconstruction of the maxillary jaw. You can see that in the front, we have an extreme deficient ridge, mainly at the horizontal aspect. In the back, we have very, very soft bone. It looks like a honeycomb. So what should be the treatment plan? We really have to think a little bit outside the box here, because we know we need to do sinus augmentation, we need to do horizontal ridge augmentation, but the big issue and problem here is what kind of temporization can we give the patient? Because if we give the patient her existing denture, you can kiss your graft bye-bye. So I banged my head for 3 nights. How would I give that patient a temporary restoration that would not jeopardize my augmentation and implants? And I came out to this idea. I'm going to place mini implants in the palatal bone. All I need is about 6 months of relieving the stress from the augmented areas. So we are going to create a fixed screw-retained restoration on mini implants, which are going to be inserted in the palatal bone. Here are the implants. Those are 1.8 to 2.2 in diameter, made by Dentatus company, and they are the only ones that can give you the ability to do a screw-retained prosthesis. So 4 implants in the front, 2 at the place of the premolars, and actually that is the planning, and you can see that the bone on the back is, again, it's like air. There is no cortex here. Actually, I was able to place those implants just by my hand. That is the other side. Again, you can note and see the density of the bone here is lacking. So we have a surgical guide. We start to do here the sinus elevation, and you can actually see here the window that was fabricated. You can see the blood vessels that run at the posterior wall, and of course you have to be very careful. And then I sit the surgical guide in the front, and I start to mark where my implants should be. And you can actually see the implant which is inserted in the lingual aspect of the maxilla. We mix graft material which was a 50% allograft, 50% xenograft, and PRF mixed together. Here are the implants according to the plan. And you can see the 4 blue screws here. Those again will be the tenting screws that will be tenting my membrane and graft material. So here are the 4 screws in the buccal aspect right here. And here is the membrane and the graft material, again, same combination and mixture. 50% xenograft, 50% allograft, and Lprf. Closing up the tissues, those are only the components of the screw-retained temporary restoration. And here is the temporary bridge, which is seated just on those mini implants. 6 months later, we send the patient for a Cbct. And what do we see on the x-ray? So first of all, in the back, we see our sinuses, the implants, and the surrounding bone around. When we go anteriorly, we can actually see here the tenting screws and the bone that was regenerated on the buccal aspect. And look how much volume we managed to get here on the buccal aspect. You actually see very nicely the implants, the mini implants are on the palatal aspect, and we have a lot of bone on the buccal aspect. So now we can go ahead, and after having the Cbct done, we can now expose the bone, place implants in the front, and take out those minis. Here you can see on a nice reconstruction the amount of bone that was fabricated on the buccal aspect. And that is the bone here on the right where the sinuses were done. Look at the tissues, how healthy the tissues look like around those mini implants. So we can now fabricate a new temporary bridge that will sit on the 4 implants in the sinuses and the new implants which we are going to insert. Now take a look. We open up the area and look at the width of bone that we managed to get in this particular case. We have to grind some bone in order to get to the tenting screws. We take them out. We place the surgical guide and we start to mark where our implants should be. And here we designed a place here for 6 anterior implants. And my preference here was to place narrow diameter implants. Those are 3 millimeters in diameter. And the idea behind was that we need as much buccal wall thickness as we can for long-term stability. This is why I advise all of you to place not the big, fat, wide implants, but the narrow implants. Because for long-term stability, we know that it will prevent shrinkage and recession. That's a 1-week post-op with the temporary and the mini implants in place. The narrow diameter implants in place. And here is a post-op panoramic X-ray that was taken about 4 to 5 months after implant insertion. So we see very nicely here the bone augmentation, the position of the implants, and everything now looks bright to move ahead, to take impressions, and to fabricate the fixed restoration, of course, with pink porcelain. That is the lower, that is the profile of the patient, and that's how she looks like. And she is the most or the happiest woman on earth. That is the upper and the lower restorations, and that is the post-op panoramic periapical views after the reconstruction had been delivered. That is a 10-year post-op of that case, functioning beautifully. She is now one of my best patients regarding oral hygiene, and I wish all my patients were like her. So that's how we started, and that's where we are. Now, 2014 was a landmark for me. Why landmark? Because all my practice and the way I do things today has changed. So everything turned upside down. And probably I was wrong in many ways. Why? Just because of this gentleman here, Dr. Salah Huways from Michigan, that came out with the concept of Osseodensification. So here is a case. A quite elderly patient, 85 years old. She comes with a lost dentition. So you can see how she looks like. There is increasing mobility, not enough bone support. You can actually see how the maxilla looks like. Everything is shaky. And she wants fixed restoration. So we look at the cone beam CTs, and you can actually note and see that on the upper right side, we hardly have any bone left between the sinus and the existing ridge. And in the front, we do have some bone, but again, that is quite narrow. But on the other hand, there is lots of trabecular bone inside. And when I see a trabecular bone, which is present, that is for me a very big advantage because I can utilize and transfer this bone into a high density bone by osseodensification. That is the upper left, which is looking exactly the same as the upper right. So we do a plan. And my initial plan was to place 6 implants in the front with osseodensification and maybe a little bit of subnasal elevation. And in the back, since we are going from only one molar to the other, we might do a minimal invasive osseodensification sinus in the right. On the left, we can do the same, but it all depends what will be in the opposing jaw. So that was my plan. We extracted the teeth, and we start now to do our osteotomies. And again, all my osteotomies nowadays are done with the Versa burrs. I'm not utilizing anymore a conventional burr. And what is osseodensification all about? Osseodensification is a novel technique for implant osteotomy preparation that increases primary implant stability by compaction and autografting of patients' autologous bone. And it involves, of course, low plastic deformation of the bone tissue. We have lots of evidence in the dental literature for osseodensification nowadays, and here you can see more than 20 publications that are available there and are coming out almost every month. Those are the traditional bone drills that we have been using over the years. Those drills were invented mostly for the metal industry and carpentry, not for drilling into bone tissue, because they extract the bone out. We would like to maintain all the bone inside. So if you are using an extraction drilling, like here on the left, you extract the bone out, and then remodeling process starts. When we go in the opposite direction with a special burr, not the standard burr, we just condense the bone sideways into the trabecula, and we would, of course, maintain all the volume. Here in a viscoelastic gel, you can see the difference between a standard drill on the right and an osteodensifying drill right here in the middle. That is a completely different story. So those are the drills which are utilized, and you can see that by doing mechanical testing, the removal and insertion torque while doing osseodensification is significantly higher than standard drilling. And the enhanced implant stability is mostly due to the spring-back effect towards the center. And no need for undersize our osteotomies with osteodensification because of the effect of the spring back to the center. So we can actually oversize the osteotomy, knowing that we will have a spring back effect that will contribute to implant primary stability. So basically, osteodensification is an autografting procedure. By autografting bone and reapplying ground particles in a compacted manner along the entire depth of the osteodensification hole, particularly at the bottom of the hole. And when you look here on the osteotomies, on the left is a standard drilling, on the right is a osteodensifying site, you can see that there is a difference because the diameter of the osteotomy is narrower when we do osteodensification. Not because of the diameter of the drill, because they are completely the same. Because of the spring back effect, we have a narrower osteotomy. This is why we have more stability and we have 3 times more bone to implant contact at day 0, as you see on the right hand side. All those parameters were published in the JOMI in 2015 by Salah Huwais, and you can look it up and see all those facts. Same was done also in an animal study in sheep with the same results. You can see the differences between osteodensification with a very high insertion torque versus standard drilling, and look at the histology, how it differs from osteodensification to standard drilling. So let's get back to our patient. So we have done the osteotomies in the front with osteodensification. We insert the implants. And now we go on the upper right and we do osteodensification sinus preparation. I mean, that is not the topic of the presentation. It's a different lecture, but we can easily follow the clinical protocols that we have designed over the past 6 years and do very efficiently and predictably sinus elevation from a crestal approach done with osteodensification. So we managed to place all the implants that we needed. We are now using a PRF block to secure our buccal areas because we don't want any resorption. So we are placing the veneer grafting on the buccal aspect, cover everything with PRF membranes, and suture it up. Now we take impressions, and we get the same day a fixed temporary screw-retained restoration that sits on the transmucosal abutments. And that is, by the way, afterwards, the final reconstruction. So here's the final reconstruction in the upper jaw. You can see nicely here the sinus elevation that was done with osseodensification and all the other implants that were inserted at the same time. Now we get to the bottom. What are we going to do in the bottom? We are going to do full clearance, placing implants both in the front and short implants in the back. That is the plan. 8 implants altogether. So you can actually see the clinical situation. You can see even the pus coming out here from the infection that was around the canine here. And we are incorporating here another principle, what I call green dentistry, because I'm going to utilize the patient's own teeth as my graft material. So basically, we have a lot of similarities between teeth and bone. They are coming from the same embryologically origin, from the neural crest, through an intramembranous pathway. And they both contain all those growth factors which are crucial for bone regeneration. The first pioneer that brought up that system that I'm utilizing was Professor Binderman from Tel Aviv, and he published in 2014 his novel procedure to process extracted teeth for immediate grafting of autologous dentin. And here you can see how teeth can be cleaned up, grinded, and then sterilized with a special solution of pH 11 that destroys all bacteria and fungi. And then we bring back the normal pH with a phosphate buffer saline. So here you can see the patient after extraction. Those are her teeth that we processed. And now we are going to do our osteotomies. And again, you can see that I do all my osteotomies with the osteodensifying burrs. Once we have done the osteotomies, we can go ahead and do the osteotomies in the back. And here we utilized specially designed short implants that open up, as you can see here. And in the front, we utilize those implants, which are the Paltop implants with the polished neck. And I mostly prefer those implants, not only because of their fine initial stability and surface area, but also the polished neck, which is a big advantage preventing future peri-implantitis. Those are the implants that open up in the back. And again, those are the implants in the front. Now we can sit the transmucosal abutments. And we are now grafting the area with the dentin particles, as you can see here. We take impressions, send it to the lab, and we get immediately the same day a screw-retained fixed restoration. And you can see how it looks like on the X-ray right at the day of the surgery. That's how she goes with for the next 3 months until we finish up her reconstruction. So you can actually see how happy the patient is, and that is a small testimonial the same day of the surgery.
I really feel great. It was a long day, a hard day, and major surgery, and just about a year since the last major surgery, and I look great, and I haven't had so many teeth in my mouth. I can't remember the last time, and I can't remember the last time I wasn't afraid to smile, and I feel like a different person. And I'm really grateful. I'm grateful that you listened to all my panic and took everything into consideration. You said it wouldn't hurt, and really didn't hurt.
All right, so here's a patient coming with a molar. And again, you can see here that there is a crack in the mesiobuccal aspect. Extraction of the tooth. 5-6 years ago, probably I would have done socket preservation. Well, nowadays, with osteodensification, we go straight ahead to the septal area. We are expanding the septum and coming from the left to the right just by doing osseodensification. Now we can seat the implant, measure stability, which is very high, placing healing abutment, and just 6 weeks later, we can open up, take impression, and finish up the restoration. That's a completely different story. Again, same principle, extraction of the tooth, going through the septum, placing our implant, grafting on top with some collagen, and look just 10 days later how the soft tissue look like. So definitely a big revolution. So I want to conclude with the last case here. A patient that refuses to do any sinus augmentation. Why? He has a neighbor that had infection. He doesn't want to hear about sinus augmentation. Is there anything we can do for that patient? Well, looking on the right side on his Cbct, you see a very narrow ridge. But we do have trabecular bone inside. So I said, well, let's give it a try. Let's try and place 5 to 6 implants from one sinus to the other, as you can see here, and construct a fixed restoration. So here is the plan. On the software, of course, we design a surgical guide. We open the ridge, and unfortunately, as seen on the Cbct, that is a very narrow ridge, as you might see here. So we see the guide, we mark where the implants should be, and now we start with the magic, with osseodensification. And take a look how the ridge opens up here, right in the bottom here, towards the palatal area here. And also take a look here on the lower left, again, for the ridge expansion, which is now fabricated by our drills. Now, I'm not here to talk about the protocol of how to use the drills. For that, I advise you to take courses. We will talk maybe about it at the end. So take a look at how we can insert implants which are 3.75 in diameter in a ridge that was initially about 2.5 millimeters in width. And take a look at the buccal aspect. There is no dehiscence or any cracks in the buccal aspect. We check stability. Stability of the implants is very high. We are utilizing our Lprf block concept to veneer graft the buccal aspect, as you can see here. And now we can take immediately impressions and get the same day a screw-retained fixed restoration. Patient is very happy. That is how he leaves the office on the day of the surgery. That's how he goes for the next 5 months or so. And that is the final restoration taken in a radiograph 6 years post-operative. So definitely a big change. So with osseodensification, do not remove the bone, just move it. I call it a smart procedure because of the simplicity, minimal invasive, atraumatic, repeatable, and time-saving. So if we look at the past and the future, no doubt that we wouldn't be able to do this type of osteotomy with a regular standard burr. I mean, with a regular standard burr, you take the bone out, you would never be able to shift or move the bone as you see here in this slide. So you have to believe in yourself, be creative, and those of you who, of course, you can't buy happiness, but you can buy a plane ticket to Tel Aviv, of course, when times are better regarding flights. So we opened up a Versa Osseodensification Academy in Tel Aviv in our teaching institute. I would like all of you, not just Paltop users, but all of you to come and take some of our courses. And we have a very nice lineup of faculty and speakers from all over the world with different topics and different subjects. And I welcome all of you to come and join us. So in order to move forward, sometimes you need to go in reverse. So I see we have quite a few questions from the audience, and I will try now to answer them one by one. So first of all, there was a question regarding socket preservation. Would the collagen sponge be sufficient? Well, to my opinion, today, just putting a collagen sponge, of course, would not be sufficient, mainly in the anterior aspect because of the pattern of bone resorption. So I would advise, especially in the aesthetic zone, either to go for socket shield therapy or partial extraction therapy, or to immediately graft and maintain a very thick buccal bone together with thick soft tissue. Another question was regarding the first case where we bypassed the nerve and we fabricated a screw-retained prosthesis. And the question was, how do we maintain the cleanness of the prosthesis? So all those patients, of course, are instructed to clean with Waterpik and other jet devices. They are coming to the office every 6 months while we unscrew the prosthesis, we clean it up, and then bring it back in. Another question was regarding the use of Lprf. So in all cases that I've shown you, we have used Lprf, and I'm a very big advocate of Lprf. And one of the biggest advantages of using Lprf is not just the healing of the soft tissues or the angiogenesis, but also we get a lot of thick keratinized tissue. And you could have seen in the cases that I presented how we are changing the way the soft tissue looks like afterwards. So not just gaining the speed of regeneration with angiogenesis, but also changing a little bit the phenotype of the soft tissues. Now, a question, am I using the same screws for tenting as the screws that I use for GBR fixation? Well, no, I'm using a special tenting screws which have a very wide head. I think the ones that I was showing here were by Osteogenics, and they would support your membrane and graft material. Now, Lprf, again, there is another question of Lprf versus PRP and PRF. Well, most of you know that almost every second week comes a new entity of APRF and SPRF, and I stick to the old protocol of the Lprf, which says 1200 RPMs, 2700 RPMs for 12 minutes. And if you want to make a PRF block out of it, then spin it for 3 minutes, take the liquid from those white cap tubes, and then mix it with your biomaterial. Another question was regarding the use of denting. Well, as you can see, throughout my presentation, we always try to use autologous growth factors. And by utilizing patients' blood and drawing the growth factors out of it, as well as using patients' dentin, which consists of all the same exact growth factors that are found in human bone, except for the fact that it is a slow resorbing agent. And it has a very big advantage when we deal with big major reconstructions. So that was regarding that question. Now, what membrane have I used for the regeneration? So I think only in one case that I've shown you today, and that was the case I was treating 10 years ago with the atrophic maxilla, I was using membrane, and that was a pericardial membrane that I was utilizing at that time. Today, I hardly use membranes. I mostly use my graft material covered with Lprf. Only in cases where I have huge defects, I would probably use a long-lasting resorbable membrane like the Ossix Plus. What about Pyramidion implants that I used in one of those cases? Well, those short implants, which come in from 5 millimeters and above, have the principle of what you are utilizing in your homes to fix paintings and any other things that you would like to hang on the wall, because they open up. And that principle, of course, adds to the big stability of the implant with a very high surface area. I have an experience of about 7 years now with those implants, and I prefer to use them mainly in posterior mandible, where I don't have sufficient height from the nerve to the ridge. When I see all my friends are invited me to come to their countries. Well, my friends, I wish I could come to all of you, but I'm afraid that in these Corona time, probably it will take a while, but still I promise each one of you to come and share with you our knowledge and to have fun together. So I want to thank all of you for joining this webinar, and I wish I would be able to see you soon in the very near future. So thank you very much and stay safe.